ये फाइब्रोमाइल्जिया वाला
थैंक यू। ये कहाँ लगाना है? साइड में? हाँ?
हो सकती है
where the pain is. We are talking about a pain in which the warning meaning is lost. So usually, basically, I must say, we had in the past mainly two types of pain. Nociceptive pain, which is the pain caused by an inflammation or a non-inflammation response to a noxious stimulus, in which we have a biochemical activation, and the paradigm is osteoarthritis. And on the other side, we had neuropathic pain, which is caused by a lesion or a disease in the central or peripheral sensory system, in which we don't have biochemical activation, but we have changes in ion channels activity. So it's a sort of black or white choice. One or the other, nociceptive or neuropathic. This, of course, left outside a lot of clinical pictures in which we don't have a nociceptive condition, nor neither a neuropathic condition as well. So this black or white division implies, as I said, that neuropathic pain is the only alternative to nociceptive pain. But this rigid classification leaves out a series of syndromic pictures that are frequently found in our daily practice. In particular, patients who show Can you hear me? Can you hear me?
Yes, we can hear you.
Okay. So, and we have patients who clinically present a broad range of symptoms outside their pain. Sorry, but sometimes.
Yeah, you can continue.
Okay.
So, antibacterial is asphyxiating absorption or noble shield that is skin dry and
And mainly, we are talking about fibromyalgia or the so-called Lady Gaga syndrome. And on the other side, we have what we now call complex regional pain syndrome type 1. But as you may feel, we have two conditions very difficult to diagnose, in which we don't have any pathognomonic signs, but in which in one case we have a widespread pain, and in the other case we have a regional pain. So from a rational point of view, it seems that the two pains are very far from them, even if we are classifying them actually as nociplastic pain. But what does it mean? what nociplastic pain really means. Well, I am sure that at least once in a life we had to go to the dentist. And usually when you are going to the dentist is doing some anesthetics to block pain before doing some work on your tooth. But if you remember, at a certain point when you are out of the dentist, you are starting to touch your face because it seems that your face is altered, that you have a sort of distorted mouth, that you have a dropped chin, which is not. Why? Just a little amount of anesthetic is doing such a tremendous changes in the feeling you have of your mouth, tongue, and chin. This is the power activity of the nervous system, which is plastic. And you need only to block, let me say, a stupid nerve, like an alveolar nerve, to have the brain thinking, oh my God, I can't feel anymore that part of the body. In that way, the brain starts to recreate a sort of distorted map. And as soon as the normal sensory inflow starts to reach the nervous system, you gradually start to feel your mouth, your chin as normal. But just think how powerful is the plastic activity in the nervous system. But this is normal neural plasticity that we use when you have to learn poetry, when you have to learn maths, when you were studying medicine. We were able to learn anatomy just because the nervous system was plastic, and the repetition of the information makes our brain change. And this is a fantastic demonstration that it takes only few days of the application of prismatic glasses to a poor owl just to modify the visual cortical projection. Only few days to reorganize the visual cortex. Okay, but unfortunately, we have also maladaptive plasticity, which is related to the ongoing painful sensation and afferences. Okay, so now we have two types of pain, one nociceptive, the other neuropathic, and this new entity that comes from the ability to the nervous system to changes in a plastic way. And as I saw, sometimes this plasticity is maladaptive. And here comes the definition of nociplastic pain, which is a plasticity of the nervous system induced by a nociceptive stimulation. So here we have a list of the characteristics of nociplastic pain. It has been published very recently. The duration is more than 3 months. The distribution may be widespread, like in fibromyalgia, but also regional, rather than in a discrete area. So not in the area of distribution of the median nerve, not in the area of the radial nerve, not in the area of the ulnar nerve, but in all your arm, which is regional and not related to any nerve lesion. So we have a non-nociceptive, non-neuropathic new entity. But in all these patients, we have a hypersensitivity to pain, not only in the area where they feel pain, but also a widespread hypersensitivity and the presence of concomitant pathologies. This has been published on pain 4 years ago. So is a brand new definition. And I know that many of you are not happy about this definition. And I'm not happy as well, because it's so close to definition of chronic pain that sometimes it makes me difficult in my clinical practice to disentangle what is chronic pain, nociceptive or neuropathic, from a chronic nociplastic pain. And just to reinforce the difficulty to make a proper diagnosis of chronic nociplastic pain, we have to consider that the three major pain entities, sometimes they are overlapping. So in the same patient, you may have more components. For example, I know that you are familiar with fibromyalgia, but sometimes in fibromyalgia, in a patient with fibromyalgia, you may have a carpal tunnel syndrome with a neuropathic pain component. You may have a tarsal tunnel syndrome in the lower limb. You may have a radiculopathy because this fibromyalgic guy has also a radicular pain L4, L5, or S1. So it's necessary for our clinician, as a clinician, not as a researcher, as a clinician, to be aware that the three types of pain can be overlap. And when we are making a written diagnosis of chronic nociplastic pain, please also add with a component, nociplastic pain, with a neuropathic component or with a nociceptive component. If the fibromyalgic patient, for instance, has a rheumatoid arthritis, for instance. But this is a very interesting point, as a nociplastic pain is never alone. They have pain, but they have also sensation of extreme fatigue. They have also sleep disorders. The sleep is not satisfying, is not restoring. They have loss of memory, and they have high level of stress, and of course mood disorders. So when you are dealing with a nociplastic pain patient, you have also to consider fatigue, sleep disturbances, sensory memory loss, and high level of stress. And please take into account this this note, stress, because here in the next slides we will not deal with what we usually define as stress. I am stressed, you are stressed, everybody are stressed. But we are talking about oxidative stress, which is the stress of the cell, and in particularly the stress of the mitochondrial chain. In the next slides, sorry. So A better way to understand nociplastic pain is consider nociplastic pain more than a single entity, a stand-alone entity. It's better to consider nociplastic pain as a continuum of a chronic pain condition. So in other terms, you are not born as a nociplastic pain patient. You become a neuropathic, nociplastic chronic pain patient. This should be stressed more and more. So this is an infographic just to show you again that chronic pain is a warning biological alarm. Chronic pain is useless because it doesn't tell us anything we need to treat our patient. And that 3 months is not really something strict because 3 months plus 1 day is chronic, 2 months and 29 days is not chronic. So consider this as a referring point, but please, it's not really theoretically necessary to have 3 months. You may describe a chronic pain also after 2 months, or when the patient has chronic pain in a sort of remitting, relapsing way. So we have 1 month of pain, 15 days of remitting, and then 1 day, 1 month, or 1 year of relapsing. So please consider 3 months just a referring point, but not really something, how can I say, fundamental. So, on the back of the slide, nociceptive, neuropathic, and nociplastic. The triad, mechanismic triad of pain. As I said, and again I want to stress, that both nociceptive, inflammation pain, traumatic pain, as well as neuropathic pain, diabetes, a nerve lesion, a localized nerve lesion, may induce central sensitization. It means that both nociceptive and neuropathic can be nociplastic, provided that they are of sufficient intensity, duration, and they have a high affective and emotional component. In this way, we may understand how it's possible that if we don't treat acute pain soon and at the best, this acute pain, nociceptive or neuropathic, may evolve, inducing plastic maladaptive changes in the nervous system, in the central nervous system, and become a nociplastic pain, which is, as I said, a continuum in the spectrum of the chronicity, pain chronicity. Another important topic, we don't need only a peripheral, how can I say, pain generator. Inflammation, trauma, overload. We may have also had something in a sort of top-down activation of the nociceptive circuitry. Because if we have an affective disorder and we, by chance, got an ankle sprain, that could be enough to develop a nociplastic pain, in which after a while you don't have any more nociceptive pain generator, and the pain is no more in the ankle, the pain is in the central nervous system. So just to take home some messages. Chronic pain, chronic nociplastic pain represents an advanced phase of the so-called maladaptive plasticity. Please take into account that the first one talking about maladaptive plasticity was Clifford Wolf in 2000. And only in 2020 we were able to develop on that basis, to develop this new entity of nociplastic pain. So, nociplastic pain does not necessarily have a single origin, as we saw, and sometimes we have a sort of mixed pain. For this reason, the search for a specific marker did not give any satisfactory results. It's very difficult. We are looking for inflammatory flags? No way. We are looking with electromyography, with CT scan, with echography, we are looking for some nerve lesion, and we don't find it. So sometimes this search is useless. Okay, but this all leaves some open questions. Is there any common denominators that we are not able to find out? A sort of invisible marker of nociplastic pain. And again, can acute pain already be chronic? What is the specific weight of genetics and epigenetics? What is the clinical picture often of a remitting, relapsing situation in our chronic pain patients? You see, since now we are able just to give you some information about this invisible marker than we have. And the invisible marker is the oxidative stress. We know that in case of chronic inflammation, or even if in the presence of neuropathy, as in the small fiber polyneuropathy, we have a high degree of oxidative stress that we can studying the level of oxidative stress, the level of the ability of the body to counteract the oxidative stress. We may study the glutathione depletion. We have to look at the critical level of some vitamins or some other compounds to give a sort of a complete frame of what is the oxidative, cellular oxidative stress. And this possibly the invisible link, linking fibromyalgia, linking complex regional pain syndrome, linking irritable bowel, linking temporal joint mandibular pain, linking many of the conditions that actually we are defined as nociplastic pain. If we go look at the energy level, energy, I mean not energy in terms of, family talking, I have feel of energy. If we are talking about cellular energy, we have to deal with the fact that in fibromyalgic patient, we have bioenergetic drop of 22% related to mitochondrial function in blood cells. It means that in fibromyalgic patients, as well as in complex regional pain syndromes patients, we have a sort of vicious circle of redox imbalance. We have an inflammation, possibly, or a lesion, maybe. Then we have a drop in the redox balance in favor of the oxidative stress. And this makes the difference. So, what we can do? If we have from one side, which is the left part of the slide, in which we have a sort of biological crisis. In fibromyalgia, the crisis is a systemic crisis, while in the complex regional pain syndrome, we have a localized regional crisis. We have an imbalance in the oxidative system. We have a mitochondrial energy deficit, and in 50% of our patients, we have a small fiber polyneuropathy. Why? Without any inflammatory, how can I say, no diabetics, no uremia, no toxic environment, etiology, nothing. But we have, in the 50% of fibromyalgic patients, we have a neuropathy of the small fibers component of the nerve. Why? Because small fibers are very sensitive to mitochondrial dysfunction. And if we don't have energy, the nerve is not working properly. So we have, in this case, we have a complex situation of oxidative stress, generally speaking, and oxidative stress in the small fibers in periphery. So we can do. My proposal is to use the oxygen ozone as a solution. Why? Because, and we will see in the next slides, ozone, a low-dose ozone, has a powerful activation of the NRF2, which control 200 genes related to cytoprotections. So oxygen ozone in a low dose has the ability to restore cellular energy and have also clinical evidences that we have already, we have. So this is the NRF2, NERV2 activation. From one side, it promotes the activation of antioxidant defensive system, increasing the level of glutathione and the activation of many antioxidant enzymes. On the other side, is able to inhibit pro-oxidant enzymes. So this action is a quite interesting action because it doesn't have any side effects. So what I am just proposing in a recent publication we did is to use oxygen ozone auto hemotherapy in fibromyalgia, because in literature there are several papers related to the activity of oxygen ozone. Unfortunately, because there's no any, how can I say, push from the chemical big pharmas to develop this treatment, which is low cost, absolutely low cost, researches are only few. But here, as you can see, some of the reports are extremely positive. So why we are talking about 5 minutes more? Why we are talking about low level of oxygen ozone in autohemotherapy? Because we have to induce a mild stress, because oxygen ozone is like exercise, which is the right part of the slide. If you do a very weak exercise, you don't train and you don't increase your energy level. If you do a right amount of physical stress, then you activate positive reactions against mild, moderate stress. While, on the other way around, if you make a strenuous exercise, then you are not able to activate an hormotic response, a positive response, because you are too much create stressors, stress compounds. Therefore, you are not able to control the pain, but on the contrary, you are increasing the pain. And this is something that happens usually in fibromyalgic patients when you prescribe exercise. They go to gym, they do too much exercise without meaning, and the day after they are in bed with a widespread pain. So, oxygen ozone, mild stress, hormetic response, because activate ROS, which is a stress signal, but is able to activate a counter reaction against this positive mild stress. So the intense stress may create a cellular damage, but a moderate, well-calibrated stress is able to increase your ability to cope with stress. It's a sort of training. Oxygen ozone therapy is a sort of training without exercise. What do we need? It's a very cheap treatment. You need a butterfly. You need, of course, a device to collect the blood. Then the blood in this bag on the right side of the slide has to be filled of a proper amount of blood. Usually 100 cc is enough. And then you mix the mixture of oxygen ozone in this bag in a proper amount. And then you reinfuse without touching the blood. So this is not a transfusion, so you don't need any authorization because it's an auto treatment. Very easy to do and very cheap. You don't need to have, for your patient, to have very expensive drug treatments. The only personal advice I want to give you is that it's better to have a tilting scale to allow an extreme, rapid but precise amount of blood that you are withdrawing from the patient. That's all. This is the setting: private hospital, big hospitals, clinics. What you need is your skill. That's all. And as you can see, this is myself a few years ago, just under a ray infusion. And on the left side of the slide, you can see the different color of my blood. On the left was the blood out, and on the right, the blood in. The blood in was more red because it was ozonizated, but also ozonized. So, of course, we are not in the condition to go into detail into the how to do auto-hemotransfusion with oxygen Ozone. But if I may do a little bit of advertise, you can have more information at the next European School in Piacenza, Italy, next September. Okay, I'm finished. Thank you very much for your attention, and I hope you enjoyed the presentation.
Robert, it was very nice presentation. And this treatment option is very newer to us. I think in the India, no one is using this treatment option. But there are so many questions which I think left over, maybe impossible in this talk. But a few of the questions in the chat box, even I have a few questions regarding this oxygen and ozone autohemotherapy. So first is what should be the indication for this treatment? In which
The indication is,
yeah,
well, the indication is very simple.
Prefer to start the oxygen ozone autohemotherapy.
Okay, the indication, whenever you have to deal with a, how can I say, difficult patient in which you have had already a list of drugs, antiepileptics, antidepressants, anti-inflammatory, and nothing work in a proper way, then you have to think about to have an oxidative stress going on. And then you go to check, and you have at least 3 ways. The first one is with a simple blood sample. You have to ask for malonyl aldehyde. You know malonyl aldehyde?
Malonyl aldate.
Okay. Lactic acid.
Yeah.
ROS, which is the reactive oxygen species, and the ability to counteract oxidative stress, which is the BAP, blood antioxidant reactive species. But I can send you, if you want, I can send you a list of blood examination that you must do, that you can spread to, okay? The only one warning is that you have to check for the glucose 6-phosphate dehydrogenases, which is the enzyme that prevent red cells to be damaged. We in Italy, in the south of Italy, we have we call, I don't know in English, anemia mediterranea, falciformis anemia. The red cells are altered in morphology. So we need to do that exam to be sure not to be harmful. But in any case, I will send you all the list of examination you should do.
Is there any particular protocol we should follow in this treatment?
Sorry, say it again.
Is there any particular protocols for oxygen ozone autohemotherapy treatment?
Oh yeah, there are many. There are many, as far as I know, many prices. If you want to have information on that, I will send you a sort of 2 or 3 slides just to give you informations how to buy the best device.
Yeah.
Another point I didn't have time to touch is the amount of oxygen ozone you have to inject.
Yes, this
Because
is
this
the question is asked by the most of the participant. How much?
because this depends, thank you, this depends on the amount of oxidative stress your patient
Yeah.
has. Sorry. So, but I will send you a sort of what I'm doing in my practice. Possibly, I'm not sure if I can to pick up the slide. No, I can't. No, sorry. But I'll send you.
Yeah.
Okay, no, I can't see it.
So just share with us, Dr. Cassel. So most of the participant can be benefited.
Well, the benefits are, yes, thank you very much. I like this question because it's something that I wanted to tell you, but I didn't want to be too overflowed.
Yeah.
You don't have to look at pain at the beginning. So don't make the mistake to ask the patient, how is your pain? You have to ask the patient, how do you feel? In terms of energy, you feel better. Usually, fibromyalgic patients, they complain about fatigue. They arrived in the afternoon and in the evening very tired. So you have to make some questions to see if they feel better in the evening, if they are less tired, if they sleep well, if the memory improves. And after on, you have to ask for the pain, because pain is much more difficult, chronic pain is much more difficult to clean up than fatigue. Because as you may imagine, when you are doing autohemotransfusion, the blood is going all over, mainly in the muscle. So the first sign that you are doing the proper treatment is that the patient is feeling less fatigue.
Yeah. And when will we expect the improvement after doing this treatment session?
Okay, again, another interesting,
And in what
very,
form specifically? Yeah, in a pain or fatigue?
okay, I want to just to reverse the question. Is there anybody there doing acupuncture? Many? Many.
I don't.
Some.
Yeah.
Okay, anyway. There are patients,
Doing dry needling, Dr. Preet Narula, she's doing
dry needling.
dry
Yeah,
needling.
yeah. Okay. So when you are doing dry needling, same patient, same acupuncture points. In some patients, they come back telling you, hey, doctor, I feel a lot of energy now. But some other come to you telling you, I sleep much more better. I feel relaxed, I feel much more comfortable. So you have two different responses with the same treatment. Why? Because we have a part of our nervous system which is the periaqueductal gray matter, which is divided in two parts. One part is the reaction part, and the other one is the quiescent part. And this depends on the, how can I say, the genotype of the patient. So there are patients with a high level of sympathetic activity, and usually they refer some more calm, more relaxation. They sleep well because their autonomic nervous system is very high, is very pushing, is very reactive, is very stress related. In some other patients in which they are much more depressed, so they are always they don't move, they stay, they are sleepy, they are how can I say, some they refer some memory loss. In these patients, you may have an increase of activity. So it depends on the balance between genotype and phenotype. And just because we don't know how the genotype is, we have to look at the phenotype and guessing and just try to develop our own casuistics.
Yeah, the management of chronic pain is very difficult. It needs a lot of work basically on the basis of
Yeah, you have to develop your, I mean, the way you just to simplify my point of view is, just because we have many drugs, just think about drugs. Just because we have many drugs for the same pathology, for the same type of pain, my suggestion is be an expert in one single drug and use that single drug, and then build around that single drug some different types of different drugs. So you are stable in your knowledge and you don't mix up things, because at the end of the story you get confused. You don't know if the activity is due by the antidepressant or by the antiepileptics, or just because you add also a little bit of non-steroidal anti-inflammatory drugs. So try to develop your own way to deal with the patient, just to make less mistake as possible, I must say.
Yeah, we can avoid the side effects of drugs also, avoiding the polypharmacy. One last question, doctor. Why not hyperbaric oxygen therapy or plasma?
Sorry, hyperbaric therapy?
Yeah, instead of using basically, or is there any comparative way we can compare the oxygen ozone autohemotherapy or hyperbaric oxygen therapy or plasmapheresis? Why should we prefer the oxygen ozone autohemotherapy?
Well, I prefer oxygen ozone for a single reason, because I can measure the amount of oxygen I'm giving. I can measure the level of oxidative stress the patient has. I can measure the changes in the hematological parameters after the treatment.
Okay.
And we have enormous amount of literature, enormous amount of basic science literature related to oxygen ozone. You cannot imagine how much, but it's only basic. It's only on the cell, it's only on the blood, it's only on cancer cells, is only related to specific biological components. And very few in the clinical practice because we don't have grants to do that. If you think that to publish, I don't want to give any title of any review, but if you go up to 4 point of impact factor, the average cost to publish is $5,000 US.
Okay. Expensive too much.
It's a lot.
Yeah.
It's a lot. So this is a bias. This is a bias because clinicians working in a private practice or also in hospital, it's difficult for us to go to the manager, say, hey, manager, I'm doing this. I did this. I have some good data. Can you give me $5,000 US to publish? Say, no, no, it's okay. And so you may publish, but you publish in a very low rank journal with a very low impact factor journal. And therefore, nobody will go there to see your paper. And then after 2-3 publications, you stop to do publications.
I think, thank you very much, Dr. Alberto. It was really nice presentation, but even I think most of us are very curious to about the detail about the treatment. So in future, if you get some chance, so we'll invite you for the detailed discussion on this topic and how we can start basically this treatment in our patients. So most of the patient, yeah.
If you want, we can plan it in a very short time. It takes no more than 20 minutes, in which I will give you all the details, where to go to buy, what to use, syringes, needles, everything.
So we can create one practical webinar on this, means how we can proceed, what type of indications patient we can select for this autohemotherapy, how to start, what are the protocols basically, that we can keep in future.
Okay, I'm ready.
Yeah, thank you very much.
Okay,
Roberto.
thank you to all.
Thank you.
To you especially, but also for the colleagues that are still online. Thank you very much.
Most of also waiting. There was also too much of waiting was there, and our platform has only 100 participants capacity. So next time we'll increase it up to 500.
Okay. So
thank you very much.
Thank you to everybody.
Thank you.